Welcome to our video on myopathies. Let's get started. In this lecture, we'll be discussing the idiopathic inflammatory myopathies, polymyositis and dermatomyositis, and inclusion body myositis. Then we'll discuss statins, glucocorticoids, and hypothyroid myopathies, all of which are high yield for the board exams. So let's start with polymyositis. For each of these topics, we're going to go through the definition all the way down through management. So let's start with the definition of polymyositis. Polymyositis is a systemic progressive inflammatory myopathy that primarily affects the proximal skeletal muscles. It affects more than one muscle group, hence it's called polymyositis. Also know that females are twice as affected as males. Polymyositis is classified as an idiopathic inflammatory disease and thought to be caused by an autoimmune process. The role of cell-mediated inflammation is proposed with CD8-positive cytotoxic T cells. Those invade the skeletal muscle myofibers, causing intrafascicular and endomysial inflammation. Polymyositis classically presents as symmetrical proximal muscle weakness. It most commonly affects the shoulder and pelvic girdles and is progressive, which means that patients' symptoms worsen over time. That is, if no treatment is sought. Now, patients will complain of difficulties picking up their children, climbing up stairs, or rising from a seated position. Neck flexor muscles can also be involved. If the esophagus is involved, it can cause dysphagia. Now, up to 33% of patients can also experience myalgias or muscle pain. Systemic involvement of the lung, causing interstitial lung disease, and cardiac involvement, causing congestive heart failure or myocarditis, may also occur. The diagnosis of polymyositis begins with a thorough history and physical exam. Important things to consider include the onset, duration, and location of the symptoms, as well as the presence of any associated symptoms that may suggest joint, lung, or heart involvement. Laboratory evaluation will show elevated inflammatory markers, such as an elevated erythrocyte sedimentation rate, ESR, or C-reactive protein, CRP, as well as leukocytosis. Serum creatine kinase, CK, will actually be markedly elevated, as well as ALT and AST. So if you're testing for antibodies, you want to focus on anti-nuclear antibodies. Those are sensitive for an autoimmune process, but it's not really specific to polymyositis. But it is found in more than 50% of patients with inflammatory myopathies. More specific antibodies include anti-Jo1, which is an anti-synthetase antibody. Now, the presence of anti-Mi2 antibodies is associated with a better prognosis. A biopsy of muscle tissue is the most accurate diagnostic method, and it will show muscle inflammation, specifically endomysial inflammation, like we discussed before. Now, this endomysial inflammation seen on biopsy is an important distinguishing feature from other inflammatory myopathies, as I'll show you later in this lecture. So, before we move on, let's quickly review some terms from histology of muscle tissue. Looking at the left side of the screen, you can see the diagram showing skeletal muscle tissue. We can see muscle fascicles. Collectively, multiple muscle fascicles are surrounded by an epimysium. Now, each individual fascicle is surrounded by a fascia, called a perimysium. And each fascicle contains muscle fibers joined together by a fascia, called the endomysium. And this is where the inflammation is primarily found in polymyositis. Now, looking at the image on the right of the screen, you can see that histology. You can see the epimysium, the perimysium, and the endomysium, respectively. Here's a histological image depicting the inflammation and invasion of muscle fibers by lymphocytes in a patient with polymyositis. Other diagnostic tests, such as electromyogram, EMG, and imaging like MRI and ultrasound, can actually show evidence of inflammation, so you can also perform those. To diagnose polymyositis, at least two of the following criteria should be present. These include the symmetrical proximal muscle involvement, positive laboratory findings, especially a markedly elevated serum creatine kinase, supportive EMG findings, and biopsy evidence of inflammation. Polymyositis and most other inflammatory myopathies are managed initially with a high-dose glucocorticoid treatment, most commonly prednisone. Alternatively, immunosuppressive agents such as azathioprine or methotrexate can be used. Particularly, these can be used as a first-line treatment in patients with contraindications to glucocorticoids. Now, IV immunoglobulins, or IVIG, can be administered with glucocorticoids, so like alongside that, especially in patients with severe disease. And you want to do that because it can help speed up the recovery process. Also, physical therapy is important, especially in patients with dysphagia, because you don't want them to aspirate. Remember how we said that if the esophagus is involved, then they can have dysphagia. A 37-year-old woman comes to the physician due to a 5-week history of progressive weakness in her shoulders. She says it's becoming more difficult to pick up her 2-year-old son. She has also had difficulty swallowing solid food for the past few days. Physical exam is significant for symmetrical shoulder weakness, but is otherwise normal. Laboratory tests show elevated serum creatine kinase and erythrocyte sedimentation rate. What is likely to be seen on a muscle biopsy? Hopefully from this question, you figured out that this patient most likely has polymyositis. She's been having progressive proximal muscle weakness, affecting primarily her shoulders, which is affecting her ability to pick up her child. And that's a common complaint of patients with polymyositis. She's also been having difficulty swallowing, so dysphagia. And again, that can affect up to 30% of patients. Now this, along with the elevated CK and ESR, suggests an inflammatory cause of the myopathy. On muscle biopsy, endomysial inflammation will be evident. All right, next in the idiopathic inflammatory myopathies is dermatomyositis. Here are the topics we'll be discussing for dermatomyositis. So once again, we'll start with definition. Dermatomyositis, similar to polymyositis, is a systemic, progressive, immune-mediated inflammatory disease that mostly affects the proximal skeletal muscles. In addition to that, dermatomyositis affects the skin, hence the name, dermatomyositis. And females are affected twice as much as males, so it's a 2-to-1 ratio, just like polymyositis. Dermatomyositis is found to be associated with malignancies, namely ovarian cancer, Hodgkin's lymphoma, and gastric cancer. Similar to polymyositis, it's an idiopathic inflammatory myopathy that's thought to be autoimmune in origin. And there's actually 2 mechanisms that have been proposed. The first is the role of interferon alpha, a pro-inflammatory cytokine, in myofiber and keratinocyte inflammation. The second is the antibody-mediated inflammation involving CD4 positive T cells and B lymphocytes invading the perimysium and leading to perifascicular and perimysial inflammation and eventually atrophy. Clinical presentation of dermatomyositis includes the signs and symptoms of polymyositis plus the skin findings. Findings specific to dermatomyositis include heliotrope rash, which is essentially erythematous skin in the periorbital region, sometimes also accompanied with periorbital edema. Gauthrin's papules are erythematous papules found symmetrically, typically on the extensor surface of finger joints. Poikiloderma is a term that refers to skin that is hyper or hypopigmented, and it's associated with telangiectasias. And this classically affects sun-exposed areas such as the upper back, referred to as the Schall sign, and that V-neck area, referred to as the V sign. Facial erythema can also be a common skin presentation. Here's an image depicting the heliotrope rash, which is a hallmark sign of dermatomyositis. You can see the macular erythema on the upper eyelid, and this is associated with some periorbital edema. As these lesions resolve, they can leave a hypo or hyperpigmented area in its place. Here we can see Gauthrin's papules with telangiectasia. Notice how they're present on the extensor surface of the finger joints, namely the metacarpophalangeal MCP and interphalangeal IP joints. Here we can see the V-sign rash. Notice the macular erythema involving the face and extending down to the V-neck area. These are commonly seen in sun-exposed areas. Here we can see the malar and facial erythema in a patient diagnosed with dermatomyositis. The diagnostic workup of dermatomyositis is similar to that of polymyositis. In contrast to polymyositis, which shows endomysial inflammation, muscle biopsy of dermatomyositis will show perimysial and perifascicular inflammation and atrophy. In addition to the muscle biopsy, a skin biopsy can be performed. And similar to polymyositis, laboratory evaluation will show elevated inflammatory markers like ESR and CRP, and leukocytosis. CK will also be high, as well as ALT and AST. And you can also find anti-nuclear antibodies and anti-Jo1 antibodies and anti-synthetase antibodies. Now similarly, anti-MI2 antibodies are usually present and they're associated with a better prognosis. So if you find this antibody in your dermatomyositis patient or your polymyositis patient, then they have a better prognosis. This is a histological slide showing perimysial and perifascicular inflammation, characteristic of dermatomyositis. We can also see perifascicular atrophy of skeletal muscles. Diagnostic criteria of dermatomyositis is similar to that criteria of polymyositis, with the addition of evidence of characteristic skin findings, as we just discussed. Dermatomyositis is managed similarly to polymyositis. In addition to the initial disease treatment, the skin disease is managed with UV light protection and topical corticosteroids. Some research also suggests the role of antimalarials, such as hydroxychloroquine, in treating the skin disease of dermatomyositis. And age-appropriate cancer screening should also be performed in patients with dermatomyositis, because this condition is highly associated with malignancies. And the screening tests include, but aren't limited to, a pap smear, a mammography, and colonoscopy. A 58-year-old woman comes to the physician due to a 6-week history of progressive weakness. She complains of difficulty combing her hair and climbing up the stairs. Physical exam is significant for symmetrical shoulder and leg weakness. Skin findings include a periorbital erythema and multiple papules on the extensor surface of her finger joints. Laboratory tests show elevated serum CK and ESR. What condition should be suspected and is highly associated with this patient's condition? Hopefully from this question, you figured out that this patient most likely has dermatomyositis. Recall that along with the muscle weakness, pathognomonic skin findings of dermatomyositis include a heliotrope rash and Gauthrin's papules. Also recall that dermatomyositis is highly associated with certain types of cancers, including ovarian cancer, lymphomas, and gastric cancer. Now, the exact mechanism of why dermatomyositis is really associated with these cancers isn't really known, but the association is strong enough that you need to know them, both in clinical practice and for boards. Next, let's discuss inclusion body myositis. And we'll go through all of these elements, starting with definition. Inclusion body myositis is an inflammatory myopathy that affects both the proximal and distal skeletal muscles. In contrast to what we've seen in polymyositis and dermatomyositis, inclusion body myositis affects males more than females. Inclusion body myositis has been found to most commonly affect elderly males, with peak incidence in patients older than 50. The exact pathophysiology of the disease is unknown, but it's thought to have an autoimmune origin. Now, the role of cytotoxic T cells is suggested, which invade and attack the endomysium, causing inflammation and deposition of abnormal aggregated proteins within the muscle tissue. Now, these proteins that you see resemble inclusion bodies, and so it's called inclusion body myositis. The weakness in inclusion body myositis has an insidious onset and it progresses slowly. And there's an asymmetrical distribution of skeletal muscle involvement. The most common initial presentation is the progressive weakness of the proximal muscle legs, and patients will present with difficulties getting up from their chair. Now, the distal hand muscles and the forearm flexors are also commonly involved and present with decreased grip strength. So these patients will often complain of difficulties performing activities that are pretty normal in the day, such as opening a jar. And of course, if the esophagus is involved, then dysphagia can occur. Because of the slow progressive nature of the disease and the nonspecific initial presenting symptoms, especially in the elderly, inclusion body myositis is often either misdiagnosed or the diagnosis is delayed for several years. History and physical examination will show weakness and atrophy of the affected muscle group. And oftentimes it's the quadricep muscles, which makes sense because we said these patients often have a difficult time standing from a seated position. You can't really do that if your quads are really weak. Severe weakness and atrophy of the quadriceps will lead to decreased deep tendon reflexes on physical exam. So that's another way to test that atrophy. Now, it's important to note that in contrast to polymyositis and dermatomyositis, lab tests will actually show normal or just mildly elevated CK. Muscle biopsy will show vacuoles and Congo red stain positive inclusion bodies. Here's a histological slide of inclusion body myositis. And here we can see the endomysial inflammation, and we can see the vacuoles as well as the inclusion bodies within the muscle tissue. The management of inclusion body myositis is the same as other inflammatory myopathies. Initial treatment with the high-dose glucocorticoid treatment, most commonly prednisone, and you can also use immunosuppressive agents as an alternative, such as azathioprine or methotrexate. And again, when would you use those alternative immunosuppressive drugs? Well, if the patient has a contraindication to glucocorticoids. And again, IVIG can be administered with glucocorticoids in patients with severe disease because you want to speed up that recovery process. Also, physical therapy is important, especially in patients with dysphagia, because again, you want to prevent aspiration. Let's discuss statin-induced myopathy next. As the name suggests, statins can induce myopathy that typically starts within weeks to months after the start of treatment. Patients usually complain of muscle weakness and pain, and it most commonly affects the proximal muscles, and creatine kinase levels will be elevated. One severe complication of statin-induced myopathy that you want to watch out for is rhabdomyolysis, and that can actually lead to kidney failure. And remember that the risk of rhabdomyolysis increases, especially when a statin is given with a fibrate. And we actually highlight that fact in one of our image mnemonics, the one on statins. So you can go back to our pharmacology chapter if you want help remembering that association. Now, management of statin-induced myopathy mainly involves the cessation of the drug, which usually resolves the symptoms. Next, glucocorticoid-induced myopathy. Glucocorticoid myopathy presents with weakness and atrophy that usually affects the lower extremity proximal muscles. It's important to note that there is no associated pain like we saw in statin-induced myopathy. So it's that weakness without the pain. And the creatine kinase levels are mostly normal. And what you should do is look for a history of glucocorticoid treatment or side effects of glucocorticoids, such as weight gain, depression, or osteoporosis. Okay, finally, let's discuss hypothyroid myopathy. Hypothyroid myopathy presents with muscle pain, cramps, stiffness, and weakness, and it affects the proximal muscles. Creatine kinase levels are elevated, and they actually can be very high in some patients. Now, other findings such as decreased deep tendon reflexes, along with myxedema, which refers to symptoms of advanced hypothyroidism, including the swelling of the body, especially the face and tongue, can also be evident. Looking for other symptoms of hypothyroidism, such as cold intolerance, weight gain, and hoarseness, can actually help you diagnose hypothyroid myopathy especially. And their most important clinical presentations and the diagnostic features you need to know. Remember that these conditions are all high yield for board exams, so it's important to be able to distinguish these from one another. Now let's wrap up with a board-style question. A 41-year-old woman presents to the physician with a rash on her face that extends down to her neck and shoulders. She complains of weakness that makes it difficult to perform daily activities, such as climbing up the stairs and combing her hair. On physical exam, symmetrical shoulder and quadriceps weakness is evident. The weakness does not improve with rest. Her temperature is 37.6 degrees Celsius, pulse is 75, and blood pressure is 134/83. Laboratory tests show a serum creatine kinase of 7,026 and an erythrocyte sedimentation rate of 100. Which of the following antibodies is most specific for this patient's disease? A. Anti-nuclear antibodies. B. Anti-centromere antibodies. C. Anti-Rho antibodies. D. Anti-Jo1 antibodies. E. Anti-SCL70 antibodies. Hopefully you were able to recognize that this patient's presentation is really consistent with dermatomyositis. She presents with symmetrical proximal muscle weakness and a skin rash that extends down her neck and shoulders, which is referred to as the Shull sign or V sign. Her labs show a markedly elevated CK and ESR, and because of those two, even though they're nonspecific, you can at least say you're thinking of an inflammatory process. And since we're dealing with myopathy, you think an inflammatory myopathy. So with dermatomyositis in mind, the correct answer, I guess the most specific finding to this patient's disease, is D, anti-Jo1 antibodies. Recall that while anti-nuclear antibodies will be present in idiopathic inflammatory myopathies, such as polymyositis and dermatomyositis, these antibodies are not specific and can be present in other autoimmune diseases. Now, anti-Jo1, aka anti-synthetase antibodies, are more specific to both of these conditions, dermatomyositis and polymyositis. Going back to our question, that makes option A incorrect because anti-nuclear antibodies are sensitive but not specific. Option B is incorrect because anti-centromere antibodies are associated with limited systemic sclerosis. Option C is incorrect because anti-Rho antibodies are associated with Sjogren's syndrome. Option E is incorrect because anti-SEL70 antibodies, also called anti-topoisomerase antibodies, are associated with diffuse systemic sclerosis. So that makes the correct answer D, anti-Jo1 antibodies. And that concludes this section.